Alright, guys, sorry about that. That was a really bad reading last time. Hopefully, you guys skipped it as suggested. Anyways, um, the HR was hazardous ratio and the CI was confidence intervals, and AHR is adjusted hazardous ratio. Um, Alright, so I basically wanted to read this as a type of segue to the main reason and gist of this video, as the society is red carpeting information censoring, like books being banned and such like that. Um, anyways, this plays into the LGBT kind of his discrimination, or historically focused on homosexual discrimination, at least with where this my framing is going. All right, I'm rambling. All right. The overall mortality for sex reassignment persons was higher during follow-ups. Adjustment hazardous ratio 2.8, 95% to confidence intervals 1.8 to 4.3 than for controls of the same birth sex, particularly death from suicide. Adjusted hazardous ratio 19.1, 95% confidence intervals 5.8, 62 2.9. Sex reassignment persons also had an increased risk for suicide attempts. Adjustment hazardous ratio 4.9, and 95% confidence intervals 2.9 to 8.5, and psychiatric inpatient care adjustment hazardous ratio 2.8, 95% cause crap, I always forget this, confidence intervals. um, Comparisons with controls matched on reassignment sex yielded similar results. Female to males, but not female to males, but not male to females, had a higher risk for criminal convictions than the respective birth sex controls. Alright, conclusions. Persons with transsexualism after sex reassignment have considerably higher risk for mortality, suicidal behavior, and psychiatric morbidity than the general population. Our findings suggest that sex reassignment, although alleviating gender dysphoria, may not suffice as treatment for transsexualism, and should inspire improved psychiatric and somatic care after sex reassignment for this patient group. Introduction. Transsexualism, interconfidence, ICD 10, or general identity disorder. DSM 4 is a condition in which the person's gender identity, the sense of being a man or a woman, contradicts his or her bodily sex characteristics. The individual experiences gender or dysphoria and desires to live and be accepted as a member of the opposite sex. The treatment for transsexualism includes removal of body hair, vocal training, yada yada yada, and cross-hormonal treatment. This is a unique intervention, but not in psychiatry, but in all medicine. The present form of sex reassignment has been practiced for more than half a century and is the internationally recognized treatment to ease gender dysphoria in transsexual persons. Despite the long history of this treatment, however, outcome data regarding mortality and psychiatric mortality are scant, with respect to suicide and deaths from other causes after sex reassignment. An early Swedish study followed 24 transsexual persons for an average of 6 years and reported one suicide. A subsequent study reported 3 suicides after sex reassignment surgery of 175 patients. Honestly, that doesn't sound too bad. A recent Swedish follow-up study reported no suicides in 6 transsexual patients, but 1 death due to complications after sex reassignment surgery. I'd like to point out that any complication or confusion with data on the surgery aspect is because most of it has been destroyed or burned, as we will learn in this video or the next one. Alright, a recent Swedish follow-up study reported no suicide. Okay, a Danish study reported death by suicide in 4 out of 29 operated male to female transsexual persons, followed up for an average of 6 years. By contrast, a Belgian study of 107 transsexual persons followed for 4 to 6 years found no suicidal deaths from other causes. A large Dutch single center study, N1109, focused on an average events following hormonal treatment. Compared the outcome after the cross-sex hormone treatment with national Dutch standardized mortality and morbidity rates, and found no increased mortality with the exception of death from suicide and AIDS in male to female 25 to 39 years of age. The same research group concluded in a recent report that treatment with cross-sex hormones seems acceptably safe, but with the reservation that solid clinical data are missing. A limitation with respect to the Dutch cohort is that the proportion of patients treated with cross-sex hormones who also had surgical sex reassignment is not accounted for. Data is inconsistent with respect to psychiatric morbidity post-sex reassignment, although many studies have reported psychiatric and psychological improvements after hormonal and/or surgical treatment. Others have reported on regrets, psychiatric morbidity, and suicide attempts after sex reassignment surgery. A recent systemic review and meta-analysis concluded that approximately 80% reported subjective improvement in terms of gender dysphoria, quality of life, and psychological symptoms, but also that there are studies reporting high psychiatric morbidity and suicide rates after sex reassignment surgery. The authors concluded, though, that the evidence base for sex reassignment, quote, is of very low quality due to the serious methodological limitations of included studies. All right. The methodological shortcomings have many reasons. First, the nature of sex reassignment includes double-blind, randomized controlled studies of the result. Second, transsexualism is rare, and many follow-ups are hampered by small numbers of subjects. Third, many sex reassignment persons decline to participate to follow-up studies or relocate after surgery, resulting in high dropout rates and consequent selection bias. Fourth, several follow-up studies are hampered by limited follow-up periods. Taken together, these limitations preclude solid and generalized conclusions. A long-term population-based controlled study is one way to address these methodological shortcomings. Here, we assess mortality, psychiatric morbidity, and psychosocial integration expressed in criminal behavior after sex reassignment in transsexual persons. In a total population cohort study with long-term follow-up information obtained with Swedish registers, the cohort was compared with the randomly selected population controls matched for age and gender. We adjusted for pre-morbid differences regarding psychiatric morbidity and immigrant status. This study design sheds new light on transsexual persons' health after sex reassignment. It does not, however, address whether sex reassignment is an effective treatment or not. Alright, methods. National registers. The study population was identified by the linkage of several Swedish national registers, which contained a total of 13.8 million unique individuals. The hospital discharge register held by the National Board of Health and Welfare contained discharge diagnoses up to 7 contributory diagnoses: external causes of morbidity or totality, surgical procedure codes, and discharge data or date. Discharge diagnoses are coded according to the 8th, 1969, 1986, 9th, 1989 to 1996, and the 10th editions, 1997, of the International Classification of Disease. The register covers virtually all psychiatric inpatient episodes in Sweden since 1973. Discharges have covered up 31 December 2003 were included. Surgical procedure codes could not be used for the study due to the lack of specific code for sex reassignment surgery. The total population register held by Swedish statistics is comprised of data about the entire Swedish population. Through linkage with the total population register, it was possible to identify birth data and birth gender for all study subjects. The register is updated every year, and gender information was available up to 2004 to 2005. The medical birth register was established in 1973 and contained birth data including gender of child at birth, national census based on mandatory self-report questionnaires completed by all adult citizens in 1960, 1970, and 1980 and 1990 provided information on individuals' households and dwellings, including gender, living area, and highest educational level. Complete migration data included country of birth for migration for 1969 to 2003 were obtained from the TPR. In addition to educational information from the census, we also obtained highest educational data for 1990 and for 2000 from the Register of Education. The cause of death register records all deaths in Sweden since 1952 and provided information on date of death and causes of death. Death events occurring up to 31 December 2003 are included in the study. The crime register held by the National Council of Crime Prevention provided information regarding crime type and data and all criminal convictions in Sweden during the period of 1973 to 2004. Attempted and aggravated forms of all offenses were all included. All crimes in Sweden are registered regardless of insanity at the time of perpetration. For example, for individuals who suffered from psychosis at the time of the offense. Moreover, conviction data include individuals who received custodial or non-custodial sentences in cases where the prosecutor decided to caution or fine without court proceedings. Finally, Sweden does not differ considerably from other members of the European Union regarding rates of violent crimes and their resolution. Okay, this seems like a pretty long article, but I think it's interesting so far. Anyways, study population identification of sex reassignment persons, exposure assignment. The study was designed as a population-based matched cohort study. We used the individual national registered number assigned to all Swedish residents, including immigrants on arrival, as the primary key through all linkages. The registration number consists of 10 digits. The first 6 provide information on birth rates, whereas the 9th digit indicates the gender. In Sweden, a person presenting with gender dysphoria is referred to one of 6 specialized gender teams that evaluate and treat patients principally according to international census guidelines. Standards of care. With medical certificate, the person applies to the National Board of Health and Welfare to receive permission for sex reassignment surgery and a change of legal sex status. A new national registration number signifying a new gender is assigned after sex reassignment surgery. The National Board of Health and Welfare maintains a link between old and new national registration numbers, making it possible to follow individual undergoing sex reassignment across registers and over time. Hence, sex reassignment surgery in Sweden requires a transsexualism diagnosis and 2. Permission from the National Board of Health and Welfare. A person was defined as exposed to sex reassignment surgery if 2 criteria were met. 1. At least one person diagnosed of gender identity disorder, diagnosed without concomitant psychiatric diagnosis in the hospital discharge register, and 2, at least one discrepancy between gender variables in the medical birth register from 1973 and onwards, or the national census from 1960, 1970, 1980, or 1990, and the latest gender designation in the total population register. The first criterion was employed to capture the hospitalization for sex reassignment surgery. That serves to secure the diagnosis and provide a time for sex reassignment surgery. The plastic surgeons namely record for reasons for sex reassignment surgery, i.e., transsexualism, but not any co-occurring psychiatric morbidity. The second criterion was used to ensure that the person went through all steps in sex reassignment and also changed sex legally. The date of sex reassignment startup follow-up um, was defined as the first occurrence of a gender identity disorder diagnosis without any other concomitant psychiatric disorder in a hospital discharge register after the patient charged changed sex status. Any discordance in sex designation across the census, medical birth, and total population registers. If this information was missing, we used instead the closest data in the hospital discharge register on which the patient was diagnosed with gender identity disorder without concomitant psychiatric disorder prior to change in sex status. The reason for prioritizing the use of a gender identity disorder diagnosis after changed sex status over before was to avoid overestimating persons' years at risk of sex reassignment person. Um, hmm. Using these criteria, a total of 804 patients with gender identity disorder were identified, whereof 324 patients a shift in the gender variable during a period of 1973 to 2004. The 408 persons that did not shift gender variable comprised persons who either did not apply or were not approved for sex reassignment surgery. Moreover, the ICD 9 code 302 is a non specific code for sexual disorders. Hence, this group might also comprise persons that were hospitalized for sexual disorders other than transsexualism. They were omitted from further analysis. Of the remaining 324 persons, 288 were identified with gender identity diagnosis at and 36 before change of sex status. Out of out of 288 persons identified after change sex status, 185 could also be identified before change in sex status. Now, I think that's personally fair. I don't think you should have to get the surgery necessarily. Um, of course, this varies from person to person, obviously. I just think it makes sense that you should be able to identify before or after. It doesn't really matter. Um, Depending on what the person wants, that's what mostly matters. All right. Anyways, the median time lag between the hospitalization before and after sex change for these 185 persons was 0.96 years, means 2.2 years, 2.2 years, SD 3.3. Gender identity disorder was coded according to ICD 8, 302.3 transsexualism, and 302.9 sexual deviation NOS. Okay. The abbreviations, I totally forget what they mean. Maybe I'm stupid here, but yeah, let's move on. Identification of population-based controls, unexposed group. For each exposed person, we randomly selected 10 unexposed persons. A person was defined as unexposed if there was no discrepancies in sex designation across the census, medical birth, and total population registers, and no gender identity disorder diagnosis according to the hospital discharge register. Control persons were matched by sex and birth year and had to be alive and residing in Sweden at the estimated sex reassignment date of the case person. Well, yeah, alive would help, I guess. Okay, to study possible gender-specific effects on outcomes of interest, we used two different control groups, one with the same sex as the case individual at birth sex matchings, and the other with the sex that the case individual had been reassigned, final sex matchings. Outcome measures. We studied mortality, psychiatric morbidity, accidents, or crime following sex reassignment. More specifically, we investigated 1. All-cause mortality, 2. Death by definite, uncertain suicide, 3. Death by cardiovascular disease, and 4, death by tumor. Morbidity included. 5, any psychiatric disorder, gender identity disorder excluded. 6, alcohol/drug misuse and dependence. 7, definite/uncertain suicide attempts. And 8, accidents. Finally, we addressed our court convictions for 9, any criminal offense, and 10, any violent offense. Okay. Each individual could contribute with several outcomes, but only one event per outcome. Cause of death register from 1952 and onwards were defined according to ICD as suicide. ICD 8 and ICD 9 codes E950 to E958, 559, sorry, and E980 and E989. Holy crap. Okay, any normal person who is still listening to me ramble knows that I have no idea what these still stand for. But I'm still reading this for the general feel of the data at hand, as stupid as that sounds. Alright, any criminal conviction during follow-up was counted. Specifically, violent crime was defined as homicide and attempted homicide, aggravated assault and assault, robbery, threatening behavior, harassment, arson, or any sexual offense. Alright, co-varieties. Severe psychiatric morbidity was defined as inpatient care according to ICD 8 codes 291, 295, 301, 303, 304, and 307. Immigrant status defined as individuals born abroad was obtained from the total population register. All outcome/covariate variables were dichotomized, affected or unaffected, and without missing variables. Statistical analysis. Alright. Each individual contributed person time from study entry. For exposed, date of sex reassignment. For unexposed, date of sex reassignment of matched case. Until date of outcome event, death, emigration, or end of study period, 31 December through 2003, whichever came first. The association between exposure, sex reassignment, and outcome, mortality, morbidity, crime was measured by hazardous ratio, with 95% CIs, taking follow-up time into account. Hazardous ratios were estimated from Cox proportional hazard regression models, stratified on match sets 1 to 10 to account for the matching by sex, age, calendar time, birth year. We present crude hazardous ratios through adjusted for sex and age through matching, and co-founder adjusted hazardous ratios for all outcomes. The 2 potential co-founder immigrant status yes/no and history of severe psychiatric morbidity yes/no prior to sex reassignment were chosen based on previous research and different prevalence across cases and controls. Alright, baseline characteristics among sex reassignment studies in Sweden, N324, and population controls matched for birth year and sex. Gender-separated analysis were performed, and a Kaplan-Meier survival study or plot graphically illustrates the survival of the sex reassignment cohort and matched the controls, all-cause mortality over time. The significance was set at 0.05. All tests were two-sided. All outcomes/covariate variables were without missing variables. Were without missing values, since they are generated from registered data, which are either present affected or missing unaffected. The data were analyzed using ASA version 9.1, SAS Institute Inc., Carey, NC USA. Alright, the ethics, I guess, which I think is interesting. The data linking of National Register required for this study was approved by the IRB at Karolinska Institutet, Stockholm. All data were analyzed anonymously, therefore, informed consent for each individual was neither necessary nor possible. Okay, then. Well, that's ethics, I guess. Jeez. Results. We identified 324 transsexual persons, exposed cohort, who underwent sex reassignment surgery and were assigned a new legal sex between 1973 and 2003. These constituted the sex reassignment exposed group. 59%, 191 of sex reassignment persons were male to female, and 41% of 133 female to males, yielding a sex ratio of 1 to 4. The average follow up time for all cause mortality was 11.4, median 9.1 years. The average follow-up time for the risk of being hospitalized for any psychiatric disorder was 10.4, median 8.1. Sorry about that. Characteristics prior to sex reassignment. Table 1 displays demographic characteristics of sex reassignment and control persons prior to study entry. Sex reassignment, there was no substantial difference between female to males and male to female regarding measured baseline characteristics. Immigrant status was twice as common among transsexual individuals compared to controls. Living in an urban area, somewhat more common, and higher education, about equally prevalent. Transsexual individuals had been hospitalized for psychiatric morbidity other than gender identity disorder prior to sexual reassignment, about 4 times other than controls. To adjust for these baseline discrepancies, hazardous ratios adjusted for immigrant status and psychiatric morbidity prior to baseline are present for all outcomes. Adjusted hazardous ratios. Mortality. Table 2 describes the risks for selected outcomes during follow-up among sex reassignment persons compared to same-sex controls of the same-sex birth. Sex reassignment transsexual persons of both genders had approximately a 3 times higher risk of all-cause mortality than controls. Also, after adjustment for covariates, Table 2 separately lists the outcomes depending on when sex reassignment was performed. During the period 1973 to 1988 or 1989 to 2003. Even though the overall mortality was increased across both time periods, it did not reach statistical significance for the period 1989 to 2003. The Kaplan-Meier curve, figure 1, suggests that the survival of transsexual persons started to diverge from that of matched controls after about 10 years of follow-up. The cause-specific mortality from suicide was much higher in sex reassignment persons compared to matched controls. Mortality due to cardiovascular disease was moderately increased among sex reassigned, whereas the numerically increased risk for malignancies was borderline statistically significant. Well, that's weird. The malignancies were lung cancer, tongue cancer, pharyngeal cancer, pancreas cancer, liver cancer, unknown cancers. Damn. So it could be due to the addiction being connected to the stress of the overall socialization of how people perceive you. So yeah, I really doubt just you're automatically you have cancer. I mean, this probably comes with behaviors. Alright. Table 2, risk of various outcomes. Population control master. Alright. Psychiatric morbidity, substance misuse, and accidents. Sex reassigned persons had a higher risk of inpatient care for psychiatric disorders other than gender identity disorder than controls matched on birth years and birth sex. This held after adjustment for prior psychiatric morbidity and was true regardless of whether sex reassignment occurred before or after 1989. In line with the increased mortality from suicide, sex reassignment individuals were also at a higher risk for suicide attempts. Though this was not statistically significant for the time period, 1989 to 2003, the risks of being hospitalized for substance misuse or accidents were not significantly increased after adjusting for covariates. Crime rate. Transsexual individuals were at increased risks of being convicted for any crime or violent crime after sex reassignment. This was, however, only significant in the group who underwent sex reassignment before 1989. That makes sense since crime has declined over time, so people would have been more violent back then. Anyways, gender differences. Comparisons of female to males and male to females, although hampered by low statistical power and associated wide confidence intervals, suggested mostly similar risks for adverse outcomes. Tables S1 and S2, however, violence against self-suicidal behavior and other violent crimes constituted important exceptions. First, male to females had significant increased risks for suicide attempts compared to both female. CI 4.4 to 19.9, and male adjusted hazardous ratio 10.4, 95% to cause interval 4.9. That's I don't know if that's cause interval, the CI, I forget. Alright, 4.9 to 22.1 controls. By contrast, female to males had significantly increased risk of suicide attempts only compared to high controls. Adjusted hazardous ratios 6.8, 95%, cause intervals 2.1 to 21.6, but not compared to female controls. Adjusted hazardous ratios 1.9, 95%, to cause ratios 0.7 to 4.8. This suggests that male to female are higher risk for suicide attempts after sex reassignment, whereas female to males maintain a female pattern of suicide attempts after sex reassignment. That's interesting. Anyways, I think there's a difference in pressure on how cisgendered society sees male to female. They sort of see that as you becoming or choosing to be a lesser almost. I don't know. It does seem like there's more of an attack on trans women more than trans men. So I can see that being the reason why trans women have it more psychologically rough. Alright. Anyways. Hold on. Alright, discussion. Principal findings and comparison with previous research. We report on the first nationwide population-based long-term follow-up of sex reassignment transsexual persons. We compared our cohort with randomly selected population controls matched for age and gender. The most striking result was the high mortality rate in both male to females and female to males compared to the general population. This contrasts with previous report with one exception that did not find any increased mortality after sex reassignment, or only noted on an increased risk in certain subgroups. Previous clinical studies might have been biased, since people who regard their sex reassignment as a failure are more likely to be lost to follow-up. Likewise, it is cumbersome to track deceased persons in clinical follow-up studies. Hence, population-based register studies like the present are needed to improve representatively. The poorer outcome in the present study might also be explained by longer follow-up period, median 10 years compared to previous studies, in support of this notion. This survival curve suggests increased mortality from 10 years after sex reassignment and onwards. In accordance, the overall mortality rate was only significantly increased for the group operated before 1989. However, the latter might also be explained by improved health care for transsexual persons during 1990, along with altered societal attitudes towards persons with different gendered expressions. Mortality due to cardiovascular disease was significantly increased among sex reassignment individuals, albeit those results should be interpreted with caution due to low numbers of events. This contrasts, however, a Dutch follow up study that reported no increased risk of cardiovascular events. A recent meta analysis concluded, however, this data on cardiovascular outcome after cross sex steroid use are sparse, inconclusive, and are very low quality. With respect to neoplasms, prolonged hormonal treatment might increase the risk for malignancies, but no previous study has tested this possibility. Our data suggested that the cause specific risk of death from neoplasms was increased about twice. Borderline statistical significance. These malignancies, however, are unlikely to be related to cross hormonal treatment. There might also there might be other explanations to increased cardiovascular death and malignancies. Smoking was, in one study, reported in almost 50% by the male to females and almost 20 by female to males. It is also possible that transsexual persons avoid the healthcare system due to presumed risk of being discriminated. I bet you that's a good chunk of it. Mortality from suicide was strikingly high among sex reassignment persons, also after adjusted for prior psychiatric morbidity. In line with this, sex reassignment persons were at increased risk for suicide attempts. Previous reports suggested that transsexualism is a strong risk factor for suicide. Also, after sex reassignment, and our long term findings support the need for continued psychiatric follow up for persons at risk to prevent this. Inpatient care for psychiatric disorders was significantly more common among sex reassignment persons than among matched controls. Um, Before, long, and after sex reassignment, it is generally accepted that transsexuals have more psychiatric ill health than the general population prior to sex reassignment. It should therefore come to no surprise that studies have found high rates of depression and low quality of life, also after sex reassignment. Notably, however, in this study, the increased risk for psychiatric hospitalization persisted even after adjusting for psychiatric hospitalization prior to sex reassignment. This suggests that even though sex reassignment alleviates gender dysphoria, there is a need to identify and treat co-occurring psychiatric morbidity in transsexual persons not only before but also after sex reassignment. Yeah, you can fix the medicalization that would automatically occur, but you can't really alleviate the socialization through medicalization to fix, you can't transition people to treat you with respect. Okay, so overall you can fix your dysphoria, but the dysphoria of how people treat you and how you view yourself through society, even cis women, there's multiple identities and archetypes to be. There's so many magazine covers and this and that and telling women to be a specific way. So of course this affects trans women as well. It massively would come down on them just like it would cis women, but with more stigma that cis women don't have. All right. Criminal activity, particularly violent crime, is much more common among men than women in the general population. A previous study of all applications for sex reassignment in Sweden up to 1992 found that 9.7% of the male to female and 6.21% of female to male applicants had been prosecuted for a crime. Crime after sex reassignment, however, has not previously been studied. In this study, male to female individuals had a higher risk for criminal convictions compared to female controls, but not compared to male controls. This suggests that sex reassignment procedure neither increased nor decreased the risk of criminal offending in male to females. By contrast, female to males were at a higher risk for criminal convictions compared to female controls and did not differ from male controls, which suggests increased crime proneness in female to males after sex reassignment. Alright, so I want to move on. If you are still following and you want me to continue reading this article, I will. Alright, moving on. Alright, so that last article I read was a Swedish study, and so ironically, this article is updated the 17th of this month, so that's convenient. Alright, as Spain advances trans rights, ironically, Sweden backtracks on gender affirming treatments for teens. Alright, so it's interesting reading a Swedish study that is now banning trans affirming care. Alright, while Spain pushes ahead with laws making it easier for transgender to change gender, other European countries that previously championed transgender rights are quietly backpedaling. A U-turn comes amid a sharp rise in people reporting gender dysphoria, where people feel that the gender assigned to them at birth is not the one they identify with. Sweden, known as the pioneer in LGBT rights, started restricting gender affirming hormones therapy for minors, allowing it only in very rare cases a year ago. In December last year, it is also limited mastectomies for teenage girls wanting to transition to a research setting, citing the need for caution. The risks outweigh the benefits. There are many risks, obviously, but I think there's always a trial and error when it comes to medical research. Most of it is through a lack of consent, like digging up bodies and like the eugenics era, but that's nor here nor there. Anyways, I think it's valuable that we figure out how to treat people without destroying them. Anyways, back in 2015, the Swedish Health Authority had stated that puberty blockers and cross-sex hormones were safe. These treatments were designed to help people with gender dysphoria transition from their biological sex to the gender they personally identify with. Sweden's National Board of Health and Welfare explains that the reason behind the rollback is that little is known about the effects of these treatments over the long term, and, quote, the risks outweigh the benefits currently. However, experts say these treatments were designed for exceptional cases in the first place. Quote, we had a protocol in place which was designed for very rare and extreme cases, and suddenly the man exploded, so we continued to use that protocol, end quote, said Michael Landon, a psychiatrist specializing in gender dysphoria, who contributed to the scientific study in which Sweden's health authority based its decision. Quote, maybe we shouldn't have done that, but I wouldn't be the one criticizing the clinicians for doing that because it was difficult. They wanted to help these patients, he told AFP. Sweden, like many other Western countries, has in recent years seen a sharp rise in diagnoses of gender dysphoria. According to the Swedish Health Authority, the trend is particularly visible among 13 to 17-year-olds assigned female at birth, with an increase of 1,500% between 1,500% between 2008 and 2018. Experts say the reason for this increase remains largely, quote, a mystery. Quote, tolerance has been on high in Sweden for at least the last 25 years, so you can't say it has changed, Landon said when asked if it was simply a result of more accepting society. Serious side effects. In 2019, there was at least 13 minors who suffered from serious side effects, according to Swedish reports. One of them had developed osteoporosis, a health condition that weakened bones after taking puberty blockers. Others have suffered from liver damage, sufficient weight gain, and depressive symptoms. This was revealed by investigative journalist Carolina Jamsby, who directed the documentary The Trans Train. Documentary. Wow, I'm so stupid. She believes the current debate shows the issue of gender affirming care for trans teens is, quote, more complex than the healthcare system and society had hoped. Quote, one aspect of this dilemma is that it has become a political issue, she told AFP. It does a disservice to this group who need a scientifically proven medical care to help them and give them a better life and a better ability to live who they are. End quote. A Swedish pediatric endocrinologist, Richard Nergarth, recently told the country's public broadcaster that the procedure teenagers with gender dysphoria go through was chemical castration. Jeez, that's a bit much. Alright, hormones save a lot of people. Alright, change is all more notable as Sweden was the first country in the world to authorize legal gender transition in 1972, paving the way for sex reassignment surgery to be covered by its universal healthcare system. As the government revisits its policies, some in the transgender community are concerned. Quote, these people might need more care and invasive procedures in the future because the decision could not be made earlier, even though the medical need was there, said Elias Jalander, youth representative of RFSL, the Swedish Federation for Lesbian, Gay, Bisexual, Transgender, Queer, and Intersexual Rights. Quote, what we're really seeing is that in some cases the hospitals do not have resources. That gives team giving gender affirming care do not have the resources to follow up in the way that is needed. Antonia Lindholm, a Swedish transgender woman, is worried that those who no longer have access to hormone treatments. Quote, hormones save a lot of people, and yes, I do feel upset that I were to come out and be 13 right now, I wouldn't have a chance. Alright, hot button issue. Several European countries are stepping back from gender affirming care. Finland, which recently passed a new law allowing trans people to change their legal gender with simple declaration, restricted hormone therapy for minors in 2020. France followed suit by calling for utmost reserve on hormone treatments for young people. Broadly speaking, transgender rights have been a hot-button issue across many countries. Hungary passed a law in 2020 banning trans or intersex people from legally changing their gender. Just last month, the UK government blocked the Scottish government's gender recognition reform bill, which made it easier for people to identify as transgender with the need for medical diagnosis. The reform, championed by Nicola Sturgeon, caused a major political row and played a role in her shock resignation at First Minister on Wednesday. One country, however, is bucking the trend. Spain has just passed controversial law allowing anyone over 16 to freely change gender on their ID card. Over 16 sounds good, but, that's not up to me and the science. Anyways, until now, adults in Spain could only register the change with a medical document attesting to gender dysphoria and proving they had undergone hormonal treatment for 2 years. Minors needed judicial authorization. That's interesting. But yeah, it seems Sweden is great right now. Alright, I will be back in the next video.